Before I introduce Dr. Bhat, just a little bit of housekeeping. Today's meeting, as all the deep dive meetings, is supported by Blood SA and other professional organizations, SAGAS and SACIDS, through grants that they supply, and obviously also some pharma companies. The management team on the deep dive, ably led by our erstwhile Professor Verberg, Estelle, who's championed these meetings since the beginning of COVID and kept them going. And of course, the work needs to be done as well, and the details and the T's have to be crossed. So thank you to Taryn and Michele. The sessions are all recorded, as you know, as Vernon explains every week. You can go back and watch them again. You can watch them in slow-mo or fast time as well, and you can reorder them, etc., as you like. Just out of courtesy, if you can just mute yourself so that you don't come through when somebody interrupts you or so. So please be careful of that. And then just all your questions along the way, you put into the chat box, and then we'll go through them at the end of the presentation, not to interrupt the flow. If you are South African, you can get CPD points. The talk is registered at Health Professions Council of South Africa. You would have logged on using your MP number, and you need to attend for at least an hour. If you're not already on the mailing list, you can join it. It's not an onerous thing, just a reminder on Friday and again on Monday morning. And at the end of the talk, there'll be a little assessment. If you can just go through it, it takes not even 5 minutes, maybe 2 minutes to fill that in, just to say where you're good and not good, and then like what aspects of it could be improved, so that you can just go through that. And then just before letting you guys, before we let Neema on loose on you and get the juices really flowing, we just want to remind you of a few things that are happening in our calendar. In just a few weeks, we have the every second year or biannual SASMA SACIDS conference, and this will be in Johannesburg this year. It starts on the Friday quite early in the morning and goes through to Sunday lunchtime. So please, if you haven't already registered, please join us. I think we've got a very good program that's been brought to us by the scientific committee. So please join us there. We have 2 publications recently. By Candace, the progress in advanced cellular and gene therapies in South Africa, and getting over the barriers to access. And then very importantly, the Cell and Gene Therapy Working Party has brought on board a white paper with looking at bringing an engaged SAPRA in a sustainable regulatory framework. Obviously, we need these things to be safe, but at the same time, we also need them to be accessible. So we would encourage you to read these. They're accessible on the website. And next week, we have Professor Michael Pepper giving us the sort of sequel to this, and that is talking about the matters pertaining to this. After Dr. Bhat, there'll be a question and answer session, and then we'll do the closing. I just want to just give a little bit of background on Professor Bhat. She's the senior hematologist and bone marrow transplant physician, pediatric oncologist with more than 12 years of experience in treating leukemias, lymphomas, rare blood disorders. She is a senior professor and team leader at the Apollo Hospitals in Bangalore. And today she's going to share with us their experience with CAR Ts and the um, and the um, and sort of give us some detail of what's happening elsewhere in the world. India to us is particularly interesting because they've focused on solutions that and access which the Western world largely has ignored, and the Western world processes are essentially out of reach for all South Africans and all Africans, with the exception of a very small percentage of people, a very rarefied atmosphere, and that is not the way we want to practice medicine. So we've been very excited to follow um, the progress in India. And what we see is that, like all good people, they're balanced. And Neema is a keen hiking enthusiast, get outdoors and scuba diving. And just in case you think that she's a pushover, she's a weightlifting champion as well. So all moms have to cook, and thank goodness most kids are not too discerning. So no criticism on your food, but we'll have to taste it before we can judge it. And now we're going to taste your CAR T experience. So thank you very much.
Thank you, Dr. David.
With
So
that,
to start sharing my screen.
Yeah. And we have 109 people on the meeting. Thank you.
Okay, is my presentation visible?
Hi, Dr. Bhat. Yes, it's visible. It's just not in presenter mode.
Yes, just starting that. Okay, is that fine?
Okay.
Perfect. You can go ahead.
Yes. Thank you. Okay, yes. Great. Good evening to everyone. Thank you again, Dr. Britton, for that kind introduction. I believe it's just past 4 in South Africa. So I'm talking to you from Bangalore, India, where it's about 7:45 in the evening. So I guess this is one of your regular meetings, weekly sessions where most of the South African hematologists gather, and you seem to have a good quorum. So thank you to the audience for joining in. Without much further ado, I will just be talking briefly about CAR T cell therapy, what's been happening in the cellular treatment world, especially back in India, and what new things we are looking to do over the next couple of years. As Dr. David said, India is sort of well placed from the medical therapeutic side, because although we don't have all the facilities, all the infrastructure, we have a lot of expat or migrated clinicians who a lot of us have trained in the US or UK or some parts of Europe. And most of us are trying to recreate the outcomes that are seen in the Western world, at least from a clinical skill standpoint. From an infra standpoint or point of view, a lot of hospitals in India are now catching up to provide the same infrastructure, whether it is mainly since we're all hematologists, whether it's bone marrow transplant units with state-of-the-art HEPA filtered rooms and positive pressure rooms, laboratory, infrastructure helping improve our cellular therapy options, or planning to start our own gene therapy clinical trials. So I think we have done sort of a decent job, at least in the last 10 years, because a lot of clinicians have migrated back to India after completing their training abroad. So today's talk is going to be a brief introduction just to CAR T-cell therapy in general, and then what's been happening. So I'm presenting from Apollo Hospitals, Bangalore, and I'm the head of the Department of Hematology, Hemato-Oncology, and Transplant Unit, as well as the Cellular Therapy Unit. So I'll start with a brief case report. This was a 56-year-old lady who was a known hypertensive with no other comorbidities. She was evaluated for complaints of left axillary swelling in January 2020. She was found to have DLBCL, which is a high-grade B-cell lymphoma, GCB subtype, double expressor type stage 2A. She had received 6 cycles of R-CHOP, and this is back in 2020. Her PET-CT post-chemotherapy showed complete metabolic response, and she presented a few months later with a skin nodule over her left arm in December 2020. So biopsy, again, of that nodule was suggestive of a relapsed DLBCL, but in a different location. The PET-CT showed metabolically active enlarged bilateral lymph nodes, again, largest one measuring 3/2 with an SUV of 12. There was another active cutaneous thickening in the left mid-arm with an SUV of 4.6 and an focal uptake in the right breast with an SUV of 4.4. She received salvage chemotherapy with 3 cycles of rice, and at that time, we did not really have CAR T-cell therapy actively available as a commercial product in India, we just had started our own clinical trials. So PET-CT after completion of treatment, which was with 3 cycles of rice regimen, showed CR or CMR. She then underwent autologous stem cell transplant following BEAM protocol in May of 2021, and she was put on lenalidomide maintenance and had a disease-free survival period of around 15 months post-transplant. Subsequently, she presented again with a right breast lump in October 2022, and the biopsy again was suggestive of relapse with the same disease morphology. She again underwent 3 cycles of RDAP, and PET-CT showed complete CMR. She received CNS prophylaxis with high-dose methotrexate for 3 cycles till 2023 February. PET-CT repeated again showed no evidence of disease. Again, at this point, there was not much else we had to offer, so we started her on maintenance rituximab and ibrutinib. About just over a year later, patient presented with another lump, again in the breast, and this again showed uptake and looked like relapsed disease. So we got in touch with Dr. Satwan Ilapu, who was one of the key people on the Zuma trial in MD Anderson, and family was very keen. They went out and met him, and she was planned for CAR T-cell therapy, and we had our Immuno Act that had been just released sort of for general patients in the Indian community, and we planned her for CAR T-cell therapy. So we'll continue about the case a little later, just a briefing. What are CAR T-cells? CARs, or chimeric antigen receptors, are modular synthetic receptors that consist of 4 main components. It has an extracellular target antigen binding domain, it has a hinge region, a transmembrane domain, and 1 or more intracellular signaling domains. The CAR T-cell therapy principle is fairly simple. We remove blood from the patient, basically conduct apheresis to get T cells, which are sent to a laboratory. So currently, we are using the Immuno Act product predominantly. That has been the most often or most used product in India. It was our indigenous CAR that was built by a business school, so Indian Institute of Management and Tata Mumbai. So these CARs were made in India in the laboratory, and the lab and the configuring was made by the business school, which is IIMB. So we make CAR T cells in our lab by introducing the CAR, and then it's expanded into millions of CAR T cells, and they're reinfused back. So this is a basic principle which most of you, I'm sure, are aware of. So leukapheresis is what is done to remove the T cells, and there is retroviral transduction with anti-CD19 chimeric antigen receptor, which is then integrated into the cell's machinery and causes transcription and protein expression and then expansion into millions of CAR T cells. So the CAR T cell interacts with the tumor cell and it activates the tumor lysis and causes cell death. In the process, it also attracts macrophages, causing release of various interleukins, tumor necrosis factor alpha, and then that causes the side effect of CAR T cell therapy treatment, like cytokine release syndrome that we are going to talk about, and also causes the tumor cell death eventually. The timeline of CAR T cell development, again, I think Dr. David may be quite familiar with this, but for the rest of us, so 1987, double chain chimeric T cell receptors were sort of conceptualized, and then it was found that most of these chimeric T cell receptors did not really have much of presence in the body despite infusion. Then they came up with single chain variant receptor, which showed that the T cells were able to last for some time after infusion. Then the concept of lymphodepletion prior to adoptive cell transfer was incorporated, especially after incorporating CD28. So this was able to take the T cells for a much longer presence and also help them expand and stay present in the body for a much longer period of time. In 2006, the first trials of CAR T therapy was conducted in patients using first-generation CAR cells. They were mostly used for ovarian cancer and another type of solid tumor, but not much clinical improvement was observed in these patients, and most of the first-generation CARs really failed to survive much, and so that was not very successful. The next significant advancement in CAR T cell therapy came when leukemia patients achieved CR after CAR T cell therapy, and this is when the second generation CARs were used. 2012 was the first pediatric patient, Emily Whitehead, who was a relapsed refractory B-cell ALL who was treated with CAR, and she continues to be in remission today, more than almost 22, 24 years post her CAR T cell therapy. 2017 was the breakthrough where Kymriah was approved by the FDA for leukemia, relapsed leukemias. And now we are looking at CAR T cell therapy for various autoimmune disorders, including SLE, ITP, and of course, we are also looking at CARs for multiple myeloma with the BCMA CARs, which unfortunately we're still awaiting complete approvals and completion of clinical trials in India, but we are very close to getting the DCGI approval for the BCMA CAR for multiple myeloma. We are also looking now to develop CARs that will be active against solid tumors and brain tumors. So that should be coming soon, probably in the next 2 to 3 years. So just for reminder, first immunotherapy, the tumor infiltrating lymphocytes used to treat cancer, it was introduced by Dr. Steven Rosenberg, and this is Linda Taylor, who was a patient with CA ovary, for whom this was not very successful. So this was the first leukemia patient and the first ALL patient. So CLL and ALL patient. William Paul Ludwig was the first adult patient to receive CAR T cell therapy at UPenn. And he was actually suffering from refractory CLL that he received in 2010 and continued to be in remission for more than 10 years until, unfortunately, in 2021, he passed away due to COVID-19. Emily Whitehead, with whose treatment I was actually involved in CHOP, was the first pediatric patient with BALL to receive CD19 CAR T cell therapy. And she continues to be in remission today, as I mentioned, more than 14 years post her CAR T cell therapy. So this is just a schematic representation of what a normal T cell looks like and the T cell receptor, and how the signaling domain is attached to the antigen recognition domain. And this goes and binds the target antigen on the tumor cell. And the genetically engineered T cells are altered to express an artificial receptor, which is the CAR or chimeric antigen receptor. And with CAR T cell response mainly to the antigen, and that leads to proliferation, to production of cytokines, and that leads to killing the target cells. So CAR T cells are considered what we so call a living drug because they proliferate and persist for long periods of time. Of course, as we use more and more CARs, we are now finding out clinically that there are downsides to it, and it may not last as long as we initially planned for it. And of course, like all treatments for cancer, the cancer cells, depending, or especially our leukemia and lymphoma cells, can be deviant enough to downregulate their CD19 expression, which will probably lead to antigen negative or CD19 antigen negative relapse, in which cases CAR T cell therapy may not really be continue to be considered as an effective treatment modality. So as we perform more and more procedures and use more and more of the CAR T cell therapy product, we are finding out that yes, it comes with its own downsides, which are apart from the initial side effects we see, which we will discuss a little bit more later during this talk. So the autologous CD19 CAR T cell products that are approved in NHL, and these are the ones that we have been working with so far. The FDA approvals have mostly come in for large B-cell lymphomas for second and third line. Now it's been moved to second line mostly. Follicular lymphoma, third line, and soon to be probably second line. Mantle cell lymphoma, second line. The lentivirus transfused CARs, which is Tisa-cell, large B-cell lymphoma for third line, and follicular lymphoma for third line. The Lisa-cell, again, a lentiviral-based transfused CAR for second and third line of large B-cell lymphoma. This is just the data that showed comparison between the ZUMA-1 trial, Juliet trial, and the Transcend trial, in which the ZUMA-1 and Scholar trials, if you compare the two historical trials, so ZUMA-1 came with a median PFS of approximately around 40 to 45 to 50%. The Juliet trial based with the Tisa-cell also showed, or we saw similar outcomes. Transcend with the Liso-cell product showed median progression-free survival of around 6.5 months, and median follow-up was around 1 year for this product. They're all used for adults with relapsed refractory large B-cell lymphomas after 2 or more lines of systemic therapy. And the 50% chance of cure was a very, very lucrative line to say CAR T-cell therapy should be used in the treatment of relapsed refractory lymphoma patients. So the multi-center CD19 CAR T-cell trials that were used in aggressive NHL, so most of the trials, mainly these 3 trials, used a cell dose somewhere between 0.5 to 2 million. So 2 million per kg in the ZUMA-1 trial, in the Juliet trial, up to 6 times 10 to the power of 8. And Transcend trial used around 1.5 times 10 to the power of 8. The ZUMA-1 trial was mostly for refractory lymphomas, whereas the Juliet and Transcends were also used in the relapsed or refractory setting. The ZUMA-1 trial did have 23% patients that had relapsed post-transplant. In the Juliet trial, this number was higher, and the Transcend trial, this number was around 35%. Bridging therapy was allowed in the Juliet and Transcend trial, and none was used in the ZUMA-1 trial. About 108 patients, which is about 90% of the patients, were enrolled and treated, as opposed to 67% in Juliet trial and 78% in the Transcend trial. The ZUMA-1 trial had an overall response of about 82% compared to Juliet, which had a much lower response rate of 52%, and the Transcend trial about 73%. CR was also best in the ZUMA-1 trial as opposed to the Juliet and Transcend trial. The progression-free survival and overall survival were also slightly better in the ZUMA-1 trial compared to the other 2. But the best overall response rate was seen in the Transcend trial, and CR rate was also seen comparatively similarly between the ZUMA and the Transcend trials. So this is the ImmunoAct product, which is, as I mentioned, is the most often used product in the Indian health setting currently. So we are able to harvest our T cells from the patient, and it is sent to the lab, which is located in Mumbai. And our vein-to-vein time is is pretty much 18 to 19 days. So between the T cells being apheresed and sent to our facility, the viral transduction happening, the expansion of T cells post-viral transduction, and then the product being shipped back to us, we have approximately 19 days. And the company is trying to shorten it slightly to maybe about 15 days. So maybe in the next few months, we'll be looking at a slightly shorter vein-to-vein times. This is mainly, as I've mentioned, the CD19 CARs, and our BCMA CAR is still in the works. This is just showing first generation, second, third generation, fourth generation, fifth generation CARs, and how they're different, and how the co-stimulation factors changed between the CARs, and the T cell receptors were different. So CD28 and 41BB, these were the extra chains, and CD3 epsilon chain domain. So these are all the differences that were added on to the ImmunoAct product. So just to highlight the clinical and manufacturing details. So the collection of T cells we are trying to get in is more than 5 million per kg. So day minus 19, the product is apheresed and sent back. Average apheresis to manufacturing interval is around 9 to 10 days. Post infusion, the hospitalization is for approximately 10 to, we've ended up with around 14 days for some patients, especially if they developed a CRS. The median post-infusion follow-up expected by the company is approximately 120 days, and this quality and success rate has been as good as 98%. The absolute lymphocyte count for manufacturing success, we're looking at more than 2 into 10 to the power of 9 per kg. So we have had a very highly efficient and robust supply chain, both for collection, the apheresis, the collection, the processing of the product, and then delivery so far with the ImmunoAct product. So the treatment schema we're looking at for most lymphoma patients at least is leukapheresis, followed by the product being sent to the laboratory. We administer lymphodepletion chemo with the help of fludarabine and cyclophosphamide with these doses. That is given on day minus 532. CAR T cell infusion happens on day 0, and then the patient is in the hospital until day 14, mainly for monitoring of CRS and ICANS, or neurotoxicity monitoring. The first tumor assessment post CAR T cell infusion is performed at day 28, and the requirement is we've been doing PET-CT at month 1, 3, 6 months after CAR T cell infusion. We do monitor the patients for neutropenia, and they require, or they receive GCSF. We give them IVIG if the IgG levels are low. We have had patients come back with grade 2 to grade 3 was the maximum CRS we have seen. We have not really seen severe grade 4 CRS. And our rate of ICANS with the ImmunoAct product has been extremely low, and I'll discuss those numbers in comparison to the global data. So about 25 to 50% of our patients have received or required a readmission for neutropenia, and have required febrile neutropenia management, GCSF support, and usually the goal for discharge is at least ANC more than 1,000. So peak expansion has been observed in CAR T cells within 2 weeks, and they're usually detectable even beyond 2 years after infusion. Each infused CAR T cell can proliferate up to more than 10,000 cells in the body. This is just a timeline that shows that day minus 543 is the conditioning. Our CAR T cell infusion, if it happens on day 0, then the early phase, or day 4 to 5, is when the immune hemostatic cytokines, the chemokine release happens, which is mainly IL-2, IL-7, IL-15. And the middle phase between day 6 to 7 is when your interleukin 6, 8, 10, interferon gamma, and TNF alpha, which are the immune modulating cytokines and chemokines release happens. The late phase, or days 7 to 11, is when the immune effector molecules, or granzymes or perforin, are released. The toxicity of CAR T cells we talk about mostly are limited to, especially in the ImmunoAct context, are limited to cytokine release syndrome and ICANS. So what we have seen with our product is our CRS is usually limited to somewhere between day 0 to day 14. I think the latest I have seen for one of our leukemia patients was up to day 18 is when they developed mild grade 2 CRS, but usually not beyond that. Neurotoxicity can happen anywhere within the 14-day period. There can also be delayed onset neurotoxicity, which starts after week 3 of the CAR-T product infusion. The other adverse effect that we have seen with our CAR-Ts, of course, is B-cell aplasia, cytopenias, and infection. We had HLH, in fact, in one of our patients who was treated for relapsed refractory B-cell ALL. That was a young teenager. He was 19 years old, and we were not able to control it with steroids, and we had to administer anakinra, also a few doses of chemotherapy to bring the HLH under control, post which he thankfully settled down, and we were able to discharge him successfully. So just to recap the cytokine release syndrome. So what exactly is it? It's a systemic inflammatory response, which is caused by cytokines that are released by CAR-T cells and other immune cells. It's a byproduct of the way CAR-T cells act, and it can result in reversible organ dysfunction and rarely irreversible organ dysfunction as well. So neurologically, patients can have any of these symptoms, but not limited to these. So headaches, changes in levels of consciousness, delirium, aphasia, apraxia, ataxia, hallucinations, tremor, dysmetria, seizures. So usually the most toxic effect we see is seizures requiring intractable seizures, sometimes requiring the patient to go to the ICU, and sometimes even intubation and ventilator support. Along with the patients can have cardiovascular imbalance or hemodynamic instability, requiring pressors, requiring infusions to control arrhythmias. We did have one of our patients who had hypotension and required low-dose noradrenaline as a result of CRS. Pulmonary effects, tachypnea, hypoxia, again, can be severe enough for the patient to require mechanical ventilation, can lead to acute kidney injury, electrolyte disturbances, and a mild tumor lysis syndrome-like picture, especially if the disease burden was heavy at the time of infusion. Gastrointestinal side effects, musculoskeletal side effects are seen. Constitutional effects like fevers, rigors, malaise, fatigue, anorexia, arthralgias are very often observed. It can lead to transient transaminitis and hypobilirubinemia as well. So the hematological side effects we have seen are anemia, thrombocytopenia, so cytopenias, febrile neutropenia, lymphopenia, B-cell aplasia, some amount of coagulopathy, elevated D-dimer, hypofibrinogenemia, mild DIC-like picture, and as I mentioned earlier, HLH as well. So this just shows what is the main treatment for CRS. So cytokines that are produced by T cells and the bystander immune cells can be inhibited by corticosteroids. So most often, the interferon gamma and IL-6 that are secreted by the activated T cells can be inhibited by the corticosteroids. However, IL-6 and mainly IL-6 requires to be controlled by tocilizumab, which is the IL-6 receptor blocker. So this is just grading of CRS. According to the CAR-Tox working group, it can be grade 1, which is limited to fever and organ toxicity, where patient requires mostly fluid management, empirical antibiotics, especially if neutropenic, supportive care with antipyretics and analgesics, X-rays, maybe tocilizumab or ciltuximab if the fever is persisting for 3 or more days. CRS grade 2 would be more severe, with the patient requiring IV fluid boluses, and if refractory hypotension, tocilizumab should be administered and repeated after 6 hours, and patient should be shifted to ICU, may have to go on vasopressors, and also with the help of dexamethasone if patient is refractory to tocilizumab, because at that point you're probably worried about HLH. Of course, supplemental oxygen has to be provided for hypoxia, and other organ toxicities have to be managed. CRS grade 3 would be hypotension, hypoxia, and organ toxicity, where patient has to be shifted to the ICU. If refractory hypotension, give tocilizumab, again, keep repeating it after every 6 hours, and vasopressors as needed. Echo has to be obtained. Dexamethasone has to be initiated and dose increased if refractory. And hypoxia has to be managed. CRS grade 4 would be similar to grade 3. However, we are looking at mechanical ventilation because it is causing significant hypoxia, and also methylprednisolone 1 gram per day to control the CRS as well as CRS versus HLH. Coming back to our case, our patient underwent apheresis with an excellent T cell collection. Her T cell collection was 7 times 10 to the power of 8. Manufacturing of CAR-T was completed in Mumbai, and we received the shipped back product. She received lymphodepletion therapy with fludarabine and cyclophosphamide after admission to our transplant unit, and tolerated her CAR-T infusion well with just nausea, and there were no other side effects. She developed grade 1 CRS and required just 1 dose of tocilizumab and stabilized after that, and was discharged successfully on day 13 post-infusion. She was readmitted after about a week from discharge with mild cytopenias and low-grade fevers. So that again resolved with antibiotics and supportive care. She did not require any further doses of IL-6 inhibitors or steroids. Follow-up for her. So her day 30 PET showed CR with no residual disease. Her PET at 3 months, 6 months, and 1 year post-CAR-T continued to show CR. Now she is about 18 months post-discharge, and she continues to be in remission, and the latest follow-up we've had with her was about 2 years post-infusion of CAR-T, and she's doing well. She has traveled back to her country, and we've not seen a follow-up PET, but clinically she seems to be stable. This is the patient and our team at Apollo. So just to look at the NextCAR19, the journey in B-cell lymphomas, what is the real-world data? What is our data for the relapsed refractory lymphoma patients? So 194 patients were leukapheresed, of which only 169 were able to receive the infusions. 3 of them had manufacturing failure. 14 of them, we lost the patient before the infusion because they had significantly aggressive disease. 2 of them had disease progression, so we were not able to proceed with the CAR-T infusion. The awaited were 29. So the efficacy evaluable cohort was around 140 around this time when the study was finalized. The breakup of the diseases for which the product was used was DLBCL in about 67% of the patient. The remaining was mostly high-grade B non-Hodgkin's lymphoma, PMBCL. We had follicular and mantle cell lymphoma. Most of it were DLBCL patients. So the responses in real world that we have seen so far was overall response rate was approximately around 75% at day 28, and month 3 was approximately 61%. CR was achieved at day 28 of 58%, and month 3 was about 57%. Partial response in about 17% at day 28, and in about 4% at month 3. Progressive disease was noted in about 20% of the patients at day 28 and 20% of the patients at month 3. 5% deaths at day 28 and about 19% deaths by month 3. So this is just a graphic depiction of the same. So overall response rate was about 75% by day 28 and 61% by about month 3. So as compared to global CAR-Ts, so the NextCAR19 fared fairly well, as in the progression-free survival probability was around somewhere between 45 to 50% at around 84 months post-infusion. The progression-free survival by around 12 months was around 43%, and coming back, it was 62% at around 6 months. Long-term overall survival comparable to global CAR-Ts, again, with NextCAR, the overall survival was approximately 71% at 6 months and 60% at 12 months. So what I think optimized the success for our patients was the right patient selection and the right timing. So the progression-free survival, sorry. Yeah. So the right patient selection made sure that most of our patients did not really require any higher support. So only 6% of the patients required vasopressors, 8% required corticosteroids, 14%, sorry. Yeah. So ICU admissions were only in about 4% of the patients. Those were early, and there were a slightly higher number of late ICU admissions in about 22% of the patients. ICANS, and this was significantly different as opposed to the other global card products, the other card products. Grade 3 to grade 4 ICANS observed were very less comparatively so about only 3% as opposed to 14% in the remaining cars. So the reduction in hospitalization cost was almost about 60%. I think the optimized patient selection significantly reduced the toxicity of the product, the ICU utilization, and hospitalization costs with very minimal compromise to the outcomes. It has a favorable safety profile compared to the other CAR-T products available. So if you see, the Axicell did have patients who were previously transplanted, about 23% of the patients. Compared to that, our patient cohort had not undergone as many transplants, not as many patients had undergone transplant. But if you look at the CRS data, the data was only about 6% of our patients had CRS as opposed to 5%, 9%, and 2.9%. So 75% had CRS, but only 6% had grade 3 plus CRS. If you look at only the CRS data, yes, it is higher, comparing especially the Lysocell data, but almost at par with the Tisacell and Axicell data. However, grade 3 plus was lesser than Tisacell and comparable to the Axicell. So grade 3 and grade 4 CRS were fairly low. What stands out was the ICANS. So ICANS was extremely low, with only about 3% of the patients experiencing ICAN, especially grade 3 plus, although 11% was the overall ICANS incidence. Still, the numbers are significantly lower while when we compare it to the Lysocell, Tisacell, and the Axicell data. So the safety concerns were extremely good when it comes to CRS and ICANS for the next CAR product. Next, coming to CAR-T in leukemias. So relapsed refractory leukemias, mostly only B-cell ALL is what we have the product available for, and relapsed CLS leukemia. So this was a patient, it was a pediatric patient, so 14-year-old boy who was initially diagnosed with high-risk B-cell ALL, mostly because of his age, and did not have any cytogenetic factors adding to his high-risk features. Initially treated on the Children's Oncology Group high-risk protocol with a 4-drug induction. So end induction marrow was negative. He was CNS negative, completed consolidation, high-dose methotrexate, and then went on to maintenance. But in maintenance, during the 5th cycle, he developed CNS symptoms with headache and blurry vision. MRI brain showed sphenoid enhancement, and CNS disease was confirmed on lumbar puncture. So nasal endoscopy was done that showed chronic inflammation, but CSF studies confirmed that he was a CNS3. Patient received systemic chemotherapy but had severe anaphylactic reaction to pegasparginase. He cleared a CSF with triple ITs, and since the family was not ready for a transplant at that point, we planned for a CAR T-cell therapy. We were also not able to continue to administer any pegasparginase for him. So efficacy to chemotherapy was considered suboptimal. So we planned for CAR T following lymphodepletion. He was successfully able to receive his CAR T cells, developed grade 2 CRS, which responded to steroids, got discharged from the transplant unit on about day 15, but post-discharge had grade 2 neutropenia and grade 1 thrombocytopenia. Now we're still a little early out from his discharge. We've just been able to discharge him about 3 weeks ago. And he still continues to have cytopenias, but otherwise seems to be stable. Translating the evidence for NextCAR19 for relapsed B-cell ALL. So this was done in about, the leukapheresis was done in about 145 patients. Infusion was received by 133 patients, and the evaluable cohort was only 118 patients. The remaining was still the data was still awaited. The characters we saw was the prior lines of therapy that the patients had received, mostly 1 to 2 lines. So 37% of the patients, 26% of the patients had received 1 line of therapy in the past, and 42% of the patients had received at least 2 lines of treatment. 32% of the patients had received more than or equal to prior lines of treatment. The prior lines of treatment included blinatumomab, but if you see the number of patients who have received blina is very small because we still have to import blina in India, and works out to be extremely expensive, so we are unable to use it. The cohort that received inotuzumab ozagamicin was slightly higher. We do have, I know, slightly more readily available. So 39% of the patients had received inotuzumab, and about 12% of the patients had undergone prior transplant. So this number is not very big, as in only 12% of the patients had undergone transplant and then gone on to CAR T cell therapy, because all of us know that that can be quite a challenging situation. The 67% of the patients had a fairly less number of percentage of blasts, so less than 5%. 30% had more than or equal to 5%, and 3% we did not really know what was the blast percentage. So pH positive in about 23% patients, pH negative in about 60% patients, and pH like in about 9%, and unknown status in 8%, because some patients would not have really undergone the complete risk stratification. Even pH status may not be known at the time of induction or at the beginning of treatment. Active CNS disease at baseline. I lost my cursor. Okay. Active CNS disease was present in about 8% of the patients, absent in 86% of the patients, and unknown in about 6% of the patients. So the response for relapsed refractory leukemia was also significantly good. So overall response rate is approximately 89%, and at day 28, and at month 3, overall response rate was around 76%. The PR was about 2%. CR was observed in 87% at day 28 and 75% at month 3. There were 8% deaths by the end of 1 month, and 16% deaths by the end of month 3. 3% patients had progressive disease despite CAR T cell therapy by the first month, and 8% of the patients had progressive disease by the end of 3 months. Comparable to global CAR Ts, so NextCAR did have a good progression-free survival in about 74% of the patients at 6 months, and the number dropped significantly to 56% at 12 months. But we have to remember that a lot of these patients had already undergone multiple lines of treatment, and they were probably prone to infections because of the multiple lines of treatment they had already received. Most of them, of course, as we discussed earlier, had not been transplanted, but multiple lines of chemo for leukemia itself can be quite myelosuppressive and might have put the patients at risk for infection. So most of the deaths were actually attributed to infections more than disease progression. So overall survival at 6 months was, 1 second. Yeah, so 12 months was around 63% of the survived patients, and 6 months was around 81%. Again, the right patient selection is key for obtaining long-term durable responses in B-cell ALL patients. The data for ICANS and ICU admissions was fairly comparable to the lymphoma data. Again, grade 3 to grade 4 ICANS was only seen about 3% of the patients as opposed to 14%. And ICU admissions were very similar to the lymphoma patients. So patients with prior transplant, if we compare it to the other T-cell products, so Tisa-cel or Kymria, about 26% of the patients had undergone transplants earlier. Brexucell, about 41% of the patients. As compared to that, NextCAR 19, only about 12% of our patients have undergone transplant prior to this. Also, the disease burden was slightly lower when compared to the other 2 CAR T-cell products, but quite comparable to the Tisa-cel or Kymria. The safety outcomes, so only 7% grade 3 plus grade 3 or grade 4 CRS overall, as opposed to 17% with the Tisa-cel and 11% with Brexucell. ICANS was significantly lower at only 5% of grade 3 or higher ICANS, which was much lower than the Brexucell ICANS as well as the Tisa-cell. Overall, ICANS numbers were also significantly lower, only 8% observed as opposed to 22% and 56%, which is quite a high number for the Tecartus product. This is just some patient education details, how to educate the patient when you are talking to them about CAR T cell therapy. You have to tell them about all the side effects of CRS, neurotoxicity, management of toxicities, to give them a brief overview, patient education regarding the CAR T cell therapy. What is the stay we are expecting if the caregiver is allowed to be present there? The fact that they're going to drop counts and going to require growth factor support. We are going to treat them with prophylactic antibiotics and treatment-related antibiotics if they are, down with prolonged fevers, when to assure them or when to advise them or educate them to follow up back in the hospital, especially after discharge. What are the CAR T cell associated toxicities? And this is just a general sort of overview to the topic. Main things that we discussed were CRS and ICANS. So ICANS is immune effector cell associated neurotoxicity syndrome, where we discussed the symptoms earlier. HLH or macrophage activation system can also be an important side effect that can be lethal post CAR T cell treatment. Massive T cell expansion, cytokine storm, severe cytopenia, multi-organ failure. These are the other side effects that can be anticipated post-CAR T cell treatment. So CRS is mainly mediated by IL-6 and is treated with IL-6 inhibitor tocilizumab, or lower grades CRS can be treated with steroids. ICANS, the key is to prevent it with antiepileptics, but if it happens, then treated with corticosteroids and ICU admission, antiepileptics, and other supportive care. HLH can be refractory to TOSI and may require the patient to receive anakinra or chemotherapy, and of course, to support and maintain hemodynamic stability and other organ functions. So when we look at the applicability of CAR T cell therapy, we have now that is an established standard of care for DLBCL, primary metastatic B-cell lymphoma, follicular lymphoma, and mantle cell, and also for relapsed refractory B-cell ALL, both in the adult and pediatric population. The emerging trial data we're looking at now for SLE or systemic lupus erythematosus, refractory systemic sclerosis, for which the data is not very clear. So basically, we're looking at resetting the immune system in severe treatment refractory autoimmune pathology. And there's a lot of international work happening in clinical trial networks, but approvals have not come through for autoimmune disorders as quickly or as robustly as it has happened for lymphomas and leukemias. ITP still something that's under investigational sort of frontier. So we are targeting the underlying pathogenic B cells or plasma cell clones. Still requires multidisciplinary discussions and board reviews to make sure that any data limitations be monitored carefully. So a few papers that have come out, especially for CAR T in autoimmune disorders like SLE and ITP. Most of the trial or patient data is from China. So there is one that article that was out in Blood. So this was actually where a small cohort of patients with SLE and secondary ITP were treated with autologous CD19 directed CAR T, and it did help both ITP patients secondary to lupus as well as primary ITP. There was another New England Journal of Medicine paper. I believe this patient was also one from China, where anti-CD19 CAR T was used in a refractory ITP patient secondary to SLE. So this was the New England Journal of Medicine patient. So 38-year-old female who had been diagnosed with ITP and had failed all previous treatments, mainly of thrombopoietins, eltrombopag, danazol, rituximab, sirolimus, cyclosporin, tacro, IVIG, HCQs, and glucocorticoids. And a patient was on eltrombopag and low-dose glucocorticoids and hydroxychloroquine as she underwent leukapheresis and then lymphodepletion and reinfusion of CAR T cells. So B cell counts before and after CAR T cell infusion. If you see at the time of screening, she had a B cell count of around 450 per cubic millimeter. By a day 14, after CAR T cell infusion, the number dropped to almost zero. And by month 6, she had gone up to about half or less than half. the number of B cells at the time of screening. So platelet counts that were initially sub 10,000, less than 10,000, slowly progressed and had hit more than 1 lakh at the time of 6 months post CAR T cell infusion. In addition to that, they also observed that ANA titers had come down from 1:320 to 1:80, and other antibody levels like anti-Rho52 and anti-SSA had also significantly reduced by about 6 months post CAR T cell infusion. So this is another cohort again from China, which looked at CAR T cell treatment in a small cohort of about 6 patients with refractory SLE and secondary ITP. This showed that I think 3 patients did attain, all patients had CR or PR. 3 attained CR and were able to discontinue all their immunosuppressants up to a period of about follow-up of 1 year. They had mostly grade 1 CRS and nobody had any ICANS. The patients who were only achieved PR showed that they had continuously accumulating bone marrow plasma cells. They had an overactivated marrow B cell signaling pathways. They had weak activity of the megakaryocytic maturation pathway and dysregulated transcription factors. So they were not able to achieve CR. So when is the right time to think about CAR T cell therapy in a patient with relapsed refractory lymphoma? It is mostly in DLBCL, primary metastatic B-cell lymphoma, follicular and mantle. But I think most of us in India have experience mostly using it for DLBCL and primary metastatic B-cell lymphoma. We have a follicular lymphoma patient who we are now considering, but we have not decided if patient has not made up their mind if they really want to undergo CAR T cell therapy. So slightly lower grade lymphomas and not very aggressive lymphomas for which there are alternative or fallback options. It is a slightly difficult modality of treatment to consider for patients because it does come with the cost implication. The optimal referral window or time to consider for a CAR T cell treatment would be when the disease burden is on the downtrend and the patient is fit. So the intersection of the two would be what is the best, because it makes we have to make sure that the patient is basically able to survive that 2 to 3 week manufacturing window that's required for the T cells to be manufactured. What is the cost of CAR T cell therapy we're looking at in India? Both lymphomas and leukemias is approximately around 80,000 USD. Patient is expected to stay in India up to 2 months, 2 to 3 months if there are no major complications, and maybe up to 4 to 5 months if they do have severe cytopenias or ICANS or CRS, which has thankfully not been the case. Post-count recovery, we try to send most of the patients back to their home country with local follow-up. With that, I will bring the talk to a close, and thank you to SA Blood and to the community for opening up the platform and letting me speak, and thank you for the patient listening.
Thank you very much, Dr. Bhat. That is a very comprehensive tour de force of CAR T treatment as it currently stands, and looking a little bit into the future. Before we have nearly 130 people online, so that's fantastic. And we're waiting for questions and messages from the audience, so you can put those in. Before we get into some of the nitty-gritty around cost, well, let's go straight into that. I think that is one of the issues that's at the heart of it, is what is the general cost range of CAR T cell therapies? Maybe you could just explore a little bit what it would cost in the US and Europe, and then what are the least expensive options around the world. And
yeah, not sure if I can comment around the world data. I would request you to pitch in, Dr. David. But in the US, the last I heard, I believe the cost for relapsed refractory lymphomas at least was approximately 1 to 1.5, at least 1 million USD is what I had heard. I think the cost was starting to come down, but this I'm talking about at least 1.5 to 2 years ago when we were doing our CAR-T, for one of our first patients. Maybe you have a better idea about the current costs in the US.
Yeah, so in the patients that we've sent, the cost of the product is in the region of 400,000 US dollars, but the actual overall cost to the
Yeah.
patient is closer to $1 million. And it's quite difficult, I think, to explain how the supportive care, leukapheresis, etc., should be so expensive. Also, no matter how hard you try to do all the workup before you go, PET scans and blood tests and stuff, it all gets repeated at
Yes.
significant cost. So I think, as I mentioned at the beginning, we need solutions that are local, for the cost reason, but also for the logistics. And that, yeah, you said the sort of 2 week manufacturing process, but often in a centralized manufacturing system, you have to get a slot as well. What is your sort of average delay in getting there, and how do you bridge the patients?
So we have been lucky. I think I've not had to wait for longer than 3.5 weeks was the longest we had to wait. And thankfully, I've not had to give any further bridging therapy. So because I believe our center is, the manufacturing center is at least able to keep up with their robust capacity infrastructure. We also had a few fallback cars, so we were able to import a couple of Malaysian cars, and I believe Singapore was where one of the centers was able to procure it from. So for one patient for whom we did not have, or we had a long time to wait, we were able to procure a Singapore car and complete the process. So I have not had to wait for too long to receive the product. But yes, in the US, we've had waiting time up to 3 to 4 months, and we would just have to keep them on some low dose bridging therapy before we finally admitted them for the lymphodepletion. So that can be a challenge. Thankfully, in India, I've not had to face that issue.
Yeah, I suppose you can get around it a little bit by cryopreserving, doing the leukapheresis and cryopreserving it, and then doing some bridging. But one wants to try and get the cells out of the patient before you start using those. Candice has given us a slew of questions, but before we go to all of them, perhaps you could just answer it in a broader context. Is that, do you, as standard, then consolidate patients with acute B-cell leukemia? Do you, as standard, consolidate those with an allogeneic transplant, or is it only in patients that have MRD? Or what are your criteria to choose that?
Yes. So in general, B-cell leukemia patients, if you're talking about adult patients, we don't transplant all of our B-cell leukemia patients upfront. No. So we risk stratify them if they're MRD positive or if they have any of the high risk features, nothing, as far as targetable, no mutations, then those are the ones with high risk features or MRD positivity that would be consolidated with a bone marrow transplant. Bone marrow transplant in India, although we are coming up with quite a few centers, still is out of reach financially for, I would say, a good majority of the population. And that is the reason I would still say not all the patients who require transplants are able to go through with it. In the pediatric population, we again look at similar data. We don't upfront consolidate all of our patients with transplants. It's either in a relapse setting, or either marrow relapse or an early sort of CNS or marrow relapse that they would definitely go in for a transplant. But otherwise, either a high risk cytogenetic or MRD positivity. So something that shows that they're refractory or resistant to chemo is what would prompt us to do a transplant, not upfront for BALLs.
So we've been very fortunate and not seen any HLH, but you mentioned it in your talk a couple of times.
Yeah.
Could you give us an idea of the incidence and perhaps like what poses a risk profile? Are there particular patients one should look out for? Are there ways to pick it up a bit earlier, and how do you manage it?
Pick it up earlier. I hope there was a way, but unfortunately, no. We have not had any particular patient features that have sort of stood out that would help us pick up who would be at a higher risk for HLH. But incidence, thankfully, HLH we've seen it only in about 1 to 2% of our patients. I would say probably 1%. Not more than that. And mostly all of them have been leukemia patients. That's what has stood out to me. So our lymphoma patients have not developed HLH, but our relapsed refractory leukemias are the ones that have developed HLH. As I said, they're usually refractory to steroids. DEXA has not really worked for most of them. I've had to use anakinra for 2 patients and even low-dose etoposide for a couple of them. So no significant features just to help us catch it early, just have a high suspicion of index, especially if the fevers are not settling with tocilizumab and steroids. You're starting to see other signs of HLH, get a ferritin at the earliest, severe cytopenias, fevers, the usual HLH markers. Have your suspicion of index sort of high, especially when fevers and cytopenias are not settling with toci or with steroids. So one factor that stood out was tocilizumab. If it was grade 2 or grade 3 CRS, which we've not had much of grade 3, but most of our grade 2 CRS responded to maybe 2 or 3 doses of tocilizumab. Thankfully, we've not had to use more than that. But anytime we're starting to use our second or third dose of tocilizumab, that is when we are starting to think about HLH, and we get our HLH markers and sort of get ready with backup anakinra and start counseling the family about that.
Yeah, thank you. So Estelle raises a question, and sorry to keep going back to this, but in terms of access, I mean, I think we're, if anything, worse. But what do you think are the key sort of features to establish just the 2 or 3 most important factors to establish your own CAR-T program? What was it that kind of allowed India to do that?
Oh, okay. I think the strong intent, number one, and I believe to a certain extent, I don't know, support from the government also, because Tata, which is one of our first cancer centers in India, they were sort of lucky enough to be able to liaise with our business school, which is our biggest network of business schools, so Indian Institute of Management in Mumbai. I think it was, I would say, almost a concoction of, that was born out of some desperate need as well as luck. And we were able to get, I think, some directions from Dr. Steve Grupp as well. A couple of team members from Tata Medical as well as IIM went to the US and received training and came back and were able to replicate those things. But I think in any setup, to be able to have a good CAR T cell manufacturing unit, you need a robust laboratory facilities, not just infrastructure, but also personnel, skill wise, and intent wise, of course, and presence of enough transplant centers, because you cannot administer or give CAR T cell therapy in a regular hospital. You would need a transplant unit or transplant setup, because these patients do become quite sick. You need to have a robust ICU as backup for most of these transplant centers or units. I think that's what I can come up with. Of course, I would say I was not really very closely involved. Unlike you, I think you have been a lot more involved in setting up the CAR-T trial in South Africa. So I have been blessed in the fact that I have been able to use the CAR-T product. I've seen patients, managed my own and referred patients and all of that. So practically on the ground, I think I've had more experience than the manufacturing unit itself. But I think that you would probably have more takeaway points than me.
Yeah, but I would agree with those things, is that you need the transplant unit, you need a quality program, you need a good base of scientists. So you can't do it without the will either, as you pointed out. I just the profile of your toxicity, the events is very similar, but the time frame seems to be a little bit different. So we had the CRS much earlier in our patients, and very rarely was it more than grade 2. So we had mostly very mild CRS, and we actually haven't had any ICANS. But I think if I was to say to somebody that was starting a program new, the thing that we had to scrabble a little bit to kind of catch up with is that there was so much focus on CRS and ICANS that you neglect to some extent the immunodepressive effects of this, the cytopenias, etc. And so
Yes.
we had some quite profound thrombocytopenia, usually resolved by a month. And we had some quite marked neutropenia, which responded very well to growth factor. In fact, the thrombocytopenia also responded well to growth factors, and the neutropenia would usually resolve within about 2 weeks, but often needed a little bit of growth factor support, and just to keep patients on prophylactic antibiotics and antivirals for at least, I would say, 6 weeks following the infusion, so that they can get through this. I mean, most of these patients will have been treated quite heavily with other immunosuppressive therapies. They don't have normal bone marrow function, which comes back to Candace's other question, which was, is there something in the profile of the patients that you select that would improve their persistence, or to improve would you choose something other about their clinical profile? I mean, you mentioned their patient selection, and obviously patients with less disease burden and less immunosuppressive therapy, bendamustine, etc. But is there something about their lymphocyte counts or the profile of the blood profile that you would choose that would give you a better chance?
Yeah, I mean, we do get basic blood counts. We try to give a gap of at least, if possible, 6 months, or at least about 3 months from other, lymphodepleting chemotherapies if the patient has already received it. As you saw, our cohort did not really have very many patients that were post-transplant. I think that was key, because post-transplant, your lymphocyte reconstitution tends to be quite delayed. So to get a robust leukapheresis and a good decent amount of T cells that can be sent for transduction, I think that comes down. And I think maybe some of the other programs, that was one of the drawback, but thankfully I have not had too many patients immediately post-transplant, at least. The ones for lymphoma post autologous transplant, the earliest I've had to take them up, for CAR-T has been nothing short of 9 months. So that was enough for autologous transplant to reconstitute. For allogeneic transplant, to be honest, I have not done many CAR-Ts post-allo transplants. The only one I have done was probably 1.5 years post the allo transplant. That was a relapse. So I think that is something. Previously transplanted patients tend to be not so great candidates for a good collection for CAR T cell therapy. Just looking at the hematological parameters, we look at baseline blood counts. If there is a doubt, then we do send sort of a quantitative CD19, CD20 T cell count, CD19, CD20 based, a flow cytometry based T cell count. If we are really in doubt, And we communicate with the lab that does our T cell manufacturing if that is a good amount. We have run into failures. One was actually a primary CNS lymphoma patient who had been heavily pre-treated, and we were not able to collect enough T cells for her. So we had to abandon it and put her back on just salvage chemotherapy regimen. But it's not happened very frequently. And if really there is a doubt, then we just run our T cells, quantitatively to see if we can get a better idea.
Yeah, I think your results were quite impressive in terms of very few patients that entered the program either had a production failure or progressed in the period in between, or for some other reason did not get the treatment. So I think that was to compliment you on that. Manolia has made a point here, and maybe it's just valuable to just share it, is that there's usually a peak in peripheral blood CAR T cells, and they're very active. So morphologically, they may look malignant, may look like
Yeah.
blasts.
Especially
So
in
just,
leukemia patients. Yes, yes,
yeah,
yeah.
just to be aware of that, I think that's a good point.
But if
And
that
then,
happens, if there is really a doubt, but then do you run a flow? What do you do
yeah.
to determine? Yeah.
Well, we didn't do any BLLs, so
Okay.
but yes, I would say that that would be the simple solution, wouldn't it be? Because they T cells straight away, you would see that. The just in terms of the lupus, I mean, this is a very kind of exciting arena, and I suppose there is a little bit of nervousness around it because these patients are have a benign background. But there were some important things that I discovered as we started exploring this and getting ready to start our own lupus trial, and that is the first thing is that the conventional treatments for these severe autoimmune diseases has a very low CR rate. There are very few patients that achieve a complete response on conventional therapy and are able to stop them. And then, whereas the CAR T in the very limited studies that have been done, but they do seem to have a very dramatic response rate. And what it would appear, and we've only treated one lupus patient so far, is that they don't get the same expansion, presumably because they don't have the tumor, they don't have the antigen to target the T cells and provide
Cause that
a
proliferation. Yes, yes,
signal for proliferation. And
yes.
then secondly, the period of B cell lymphodepletion is actually quite short. That most of them recover their B cells within around 3 months. But because the disease is not a tumor that you can measure easily on a marrow or a PET scan, the optimum result takes longer. You see the best results around 6 months to a year after
Yes,
healing of the nephritic syndrome, or and of course permanent damage will not go away. Severe joint destruction,
correct.
severe renal dysfunction will not go away, but the inflammatory component will resolve, and so it takes a long time to see that response.
So you've done one lupus patient. You said I've not been lucky enough to do any benign hematological, no lupus and no ITPs or anything of that sort. But you've done one lupus, and how far is the
We have
patient?
done one as a kind of named patient
Okay.
outside of the trial, with dramatic clinical effects, but still quite early days. So
Okay.
they were a patient with neuro lupus and have had dramatic improvement, but they had very little in the way of measurable,
Disease, so to say, yeah.
markers that we
Markers.
can measure, and we feel it's a bit early to do the MRI, but we're waiting for that, and that will be in the next month, actually. Here's a provocative question. The future of CAR Ts, will it go from in vitro to in vivo manufacture? Before you answer that, let me just highlight that these vectors are viruses, basically, and that the body is very good at getting rid of naked DNA and naked
Right.
RNA. It doesn't like it around. So I think there's a way to go. We have seen the nanoparticles, but maybe you wanna answer that. Do you see this changing?
Uh, I think the next way to go would be dramatic way forward with the allogenic CAR T more than in vivo manufacturing. I'm not sure until we get the 100% benefit from alloreactive T cells, as we are now starting to explore for hematological and more so for solid tumors. I think that would be the next way forward. In vivo manufacturing of CARs, as you said, correctly, to get the virus to reach the T cells and transduce them, they would have to be coated with some sort of I don't know, like a capsid or something like that that would evade the immune system enough to get the virus into the T cells. So that would be the bigger challenge. So if some such innovative technology comes by, then maybe. But I think the allo T cells is what we are, from what I've learned and seen, and I've not used any, of course, and I don't think we have any in India right now. But I think that's where we are headed next, sort
So
of off the
a
shelf.
provocative question on my part is that, because of the toxicity of CD19 bispecific antibodies and the neurotoxicity, all the original trials excluded patients with CNS disease. But there does seem to be, quite good results in patients with primary CNS disease without
Mhm.
an increase in the toxicity there. And in the solid tumor arena, partly because CNS tumors are so resistant to conventional chemotherapy and radiation, they seem to, and they have some unique targets. They've also been isolated as a kind of potential next or first step into the solid tumor arena. You haven't you haven't been part to any of those, or have you treated any primary CNS diseases?
No, we actually had one patient that I was prepping. Um, for CAR T for a primary CNS lymphoma, but he ended up being extremely refractory, and unfortunately, we lost him even before the leukapheresis. I mean, we had
Yeah.
counseled the family, prepped them, started his, debulking sort of chemotherapy, but didn't really make it. The other primary CNS lymphoma is the other lady I was talking about. She'd already received multiple lines of chemo previously, and her collection failed. So I've not been lucky to do any primary CNS lymphomas, not until now.
Yeah. And another area that appears to be quite attractive is mantle cell lymphoma. And of
Mhm.
course, with the new Bruton kinase inhibitor results, there's going to be stiff competition here. Um,
Yes.
but again, the cost of these targeted therapies are quite substantial. And in South Africa, they're around just under R1 million a year. So that's about 65,000 US dollars. So, for ongoing therapy, they start balancing out if you can start talking about the numbers that you're talking as sort of $80,000.
Mhm.
Uh,
Mhm.
that would be competitive. Yeah. Okay. I don't know if there are any more. Uh, okay. If you go, there's a there's a question here about CPD. Blood Essay on their website has a link that you can go to, and you can ask them as well questions on that. I'm not sure that we can offer CPD for people outside of the country, but they'll be able to answer that question for you. It remains for me to thank Professor Bhat for your time, your obvious base knowledge and familiarity with the topic comes through very well, and it's great to be able to sort of share into that knowledge and experience and dive deeply, as we like to say on this meeting. It's a credit to you that over 100 people have stayed until well into the question time. So thank you.
Thank you, Dr. David.
Okay. Just a reminder for everyone to do their questionnaire on the way out. You'll be prompted as you leave. Okay. Thank you.